In sympathetic crashing acute pulmonary edema, the first 10 minutes of management are critical. The focuses of therapy should be on early application of non-invasive ventilation and aggressive use of high-dose nitroglycerin. What we shouldn't be reaching for early in resuscitation is furosemide. Our gut says that we should be giving these patients a big slug of loop diuretics because they've got a ton of fluid in the lungs. But the problem is that many of these patients aren't actually total body fluid overloaded. They've actually just had fluid shifts from the splanchnic circulation into the central circulation. Research dating back decades shows that less than 50% of these patients have total body volume overload. And a lot of the patients who do have volume overload have end-stage renal disease, and there's no dose of loop diuretic that's going to get those patients to diurese. We even have some data showing that preload increases in the first 10 minutes after giving a dose of furosemide. Just one more reason to avoid this intervention. For all those reasons, we shouldn't be reaching for loop diuretics early in management. Instead, after we stabilize the patient with non-invasive and high-dose nitroglycerin, we can assess their volume status using things like IVC, JVD, lower extremity edema, and use all of that information together to determine whether the patient needs a loop diuretic or not. The bottom line is that there's really no role for loop diuretics in the early management of patients with SCAPE. Instead, we should focus on non-invasive ventilation and high-dose nitroglycerin.